Good morning, all. In today's CCR, we initially will have a brief introduction to our department, followed by case discussion. So, regarding department, our department was established in 2012 June. It was the first super specialty branch which was started in our institute. From 2019 July, we have started DM cardiology course also. The enrollment of 4 students every year. And currently we are having 12 residents with us. And regarding consultant, Dr. Ramanand Sinha is professor and head of department, Dr. Deepesh Agrawal sir, me, Dr. Rajiv Sharma, and Dr. Aditya Goel, who has joined as assistant professor recently. We have very strong team of pediatric cardiology with us, headed by Dr. Sanjay Khatri sir, also Dr. Kanupriya Chaturvedi and Dr. Prerna Bhatt. Regarding facilities and infrastructure, OPDs, IPDs, non-invasive cardiology, which includes Holter, echo, ECG and all, and invasive cardiology, which is angiography, angioplasty and other procedures, as we will discuss. In OPD, we have routine OPD clinics. Regarding other than that, lipid clinics, arrhythmia clinic for pacemaker patients, arrhythmia patient, and heart failure clinic. These are the bed. We have nearly 45 beds in our department. With all bed is equipped with central monitor and electrical and mechanical support, and bedside echography is also available. We have 10 ECG machines, 3 Holter machine, and one TMT machine is actually 2. One is in medicine department, and 3 echo machine. And we have high-end Philips machine, which is equipped with transesophageal as well as 3D imaging, which is the most advanced imaging in echocardiography. This is regarding data of OPD in last 3 years, and this year data is also included till May. So we can see we have good OPD numbers, IPD numbers, and very good number of echos done every year. Regarding invasive cardiology, we have 3 cath labs in our department. One is Philips FD10, which was installed in 2012, then Philips FD20, and one is latest Philips Avzeron, which have facility of 3D reconstruction, simultaneous CT and roadmap facility, and this is the most advanced cath lab till now. These are the cath labs we have. We are doing all the procedures, including adult, pediatric, intervention radiology. We have intervention radiology team also with us. Regarding spectrum of work, we are doing all routine angiographies and angioplasty, all wall-related procedures, structural heart disease, which includes atrial septal defect, ventricular septal defects, and all other cardiac structurally defect, like if patient is having hypertrophic cardiomyopathy, we can ablate with alcohol septal ablation. So these are all included in the structural heart disease, in which structure of heart is disease, and we can modify the disease itself, or we can change the the prognosis of the disease by some procedures. Endovascular procedures commonly done. Pacemaker implantation. We are second in Rajasthan to have maximum number of pacemaker implantation done after SMS. Then AICD device, cardiac resynchronization therapy with and without defibrillator. This one is the device which is used to improve ejection fraction of heart. Previously it was thought that once your heart is weak, then you can't do nothing except dying. But now we have this therapy by which ejection fraction can be increased, and definitely we have transplant team also with us if patient is having severe heart failure, not responding to inotrope and other therapies. Then electrophysiological study and radiofrequency ablation commonly done at our center. This is the spectrum of work. We can see that pointer, Shweta? Okay. So this is aortic aneurysm, which is closed with the endovascular graft, and if we implant the graft here, it will it will get sealed off with this technique. Then we have carotid procedure done by our neuro interventionist, and renal angioplasty procedures, which is also done at our center. This is the procedure, wall-related procedure, that is balloon mitral valvotomy, which is commonly done at our center. We have published one paper also on this regarding new innovative technique for doing it safely. This is ASG device closer, which is being done. Is the video? This was as I was talking. This is CRTD device. It has 3 leads in this. This lead, which is having 4 poles, is used to increase ejection fraction of heart. Before coming to this slide, I'll discuss this slide. If you go to OPD, cardiology OPD, 10% of the patients are roaming with CD that I have 80% blockage, I have 70% blockage, I have 90% blockage. And this is very common scenario in cardiology OPD. So we have this machine, what fractional flow reserve. If patient is having 80% stenosis and it measures pressure proximal to the obstruction and distal to the obstruction. If pressure drop is more than 20%, then it suggests it's a significant stenosis. If it is not, then regardless of the severity of stenosis on angiography, stenting is not done. Many of our colleagues has also benefited with this technology in our institute also. So this is very good technique available in only few centers. Similarly, this modality, intravascular ultrasound. Now we can see vessel in situ, but how much is the lipid burden, how much is the obstruction, how much is the calcium, whether stenting will be useful or not. If stenting is done, what will be the long-term data? If stent will be placed, whether it will expand or not. So we can see the vessel prior first. And if we have done stenting, we can see whether it is been done properly or not. We can assess after doing ultrasound. So once stent is placed, we see whether it is well opposed or not. Proper advantage of these techniques is first, whether stenting to be done or not. If it is done, then it should be safe and effective in long term. So we are commonly doing this procedure, and again this procedure is available only in few centers. And one more. This is also used in technique. If it is having very severe calcification, you must have seen that. This is a very common saying. So this is calcium. So first we see whether it is inside the lumen by ultrasound. If it is inside, we can do the rota ablation as ablation burst, which rotates at the speed of 1,60,000 rotation per minute, and it drills the calcium and can enhance the delivery of this stent. If stent is implanted in presence of calcium, it will not expand and can get blocked either in a month or 2 and can lead to stent thrombosis. So this technique is useful when stent is not negotiating first or not expanding properly.
What happens to the calcium debris, Rajiv? It goes out into the flow, or
yes, sir, it goes out into the flow because it rotates very fast. So debris is very fine. So it goes off with the saline, because we insert saline also in the vessel simultaneously. This is the most important aspect. Research paper. We have 24 publication in last 3 years. And we have good team of our residents who are working 24 hours, and we have 3 resident dedicated in research at one posting. And we are regularly organizing workshop for pacemaker, how to implant pacemaker, how to do pacemakers, follow up, chronic total occlusion of the vessels, bifurcation lesions, intravascular ultrasound, so that resident can get exposed to these newer therapies. These are the few papers published from our center.
Is there any role of intracoronary laser?
Yes, sir. So that's why we have chronic total occlusion. If vessel is completely blocked, either patient is having acute MI or it is blocked since long. So if it is blocked, we can't insert wire. In that case, what we are doing, we are having laser directly to that point that will drill that lesion and go through that. So we are using SOS basis, sir. Because that is uncommon, because usually blockage get drilled with wire only. So in nutshell, we are doing all the procedures in cardiology safely and effectively. So in today's case is regarding a 6-year-old boy with intractable palpitation.
So my presentation is 6-year-old boy with intractable palpitations. A 6-year-old boy, resident of Bharatpur, Rajasthan, came with chief complaint of recurrent palpitations since 2 years. He was asymptomatic 2 years back. Then he started developing palpitation episodes, sudden onset, initially for 3 to 4 minute duration, later increased to 5 to 6 hours duration since last 4 months, with increased frequency, every alternate day hospital admissions. No postural variation, no association with physical activity. Initially got relieved abruptly on its own, later required IV medication since last 4 months. Patient unable to attend school. He used to have IV cannula in situ in left arm and repeatedly got admission alternate day for IV medication. No chest pain, no altered sensorium or loss of consciousness, fever, body pain, weight loss, fatigue, swelling over the body, shortness of breath, bluish discoloration of body. No history of similar illness in the past, no medical or drug history before last 4 months. Normal vaginal delivery at term with no antenatal or natal complications, normal developmental history. He received IV amiodarone, verapamil almost every alternate day since last 4 months. Not able to attend school properly since last 4 months due to frequent occurring palpitation episodes leading to hospitalization. No history of similar illness in the family. No history of sudden cardiac death in the family. So, a 6-year-old boy presented with intractable recurrent paroxysmal palpitations since 2 years, which got exacerbated in last 4 months, requiring frequent hospitalization. So on the basis of this, what are the possibilities on anyone please? So we majorly divide into 2 causes because it is palpitation. So we think of one is cardiac or it may be a non-cardiac causes. In cardiac causes, it may be supraventricular tachycardia, ventricular tachycardia, long QT syndrome, short QT syndromes, Brugada syndrome, hypertrophic obstructive cardiomyopathy, congenital heart diseases. Non-cardiac, hyperthyroidism related arrhythmias, drugs like beta agonist, electrolyte imbalance, and anxiety. A physical examination on presentation of a child when he came to us when he was asymptomatic and was not having palpitation he was conscious, alert, oriented to time, place, person, comfortably lying on bed, 110 centimeter height with 22 kg weight and BMI is 18.2 kg per meter square. Blood pressure is 110 by 70 mm Hg in right upper limb with appropriate size cuff. 110 per minute pulse regular or peripheral pulse is palpable. 20 per minute respiratory rate regular and 98 degree Fahrenheit taken orally. Cardiovascular systemic examination. Normal precordium, no visible pulsations, apex impulse not visible. Apex beat felt in left fourth intercostal space, medial to mid clavicular line. No parasternal heave or thrill present. S1 and S2 heard normally and no murmur. Normal CNS examination, no focal neurological deficit, soft non-tender abdomen, no hepatosplenomegaly, bilateral air entry equal with normal breath sounds. So this is the ECG of a child on presentation. So anyone, please. So as you can see, it is rhythm is regular, heart rate is 120 per minute, axis is normal with normal P wave morphology, normal PR and QRS duration. So ECG on broad basis it is normal. So this was the ECG which the child brought with him when he used to have palpitation, got repeated admission. So this was what along with him. So anyone, please. So it is ECG which we see that rhythm is regular, heart rate is 210 per minute with normal axis, QRS is wide, we see, LBVB morphology. So on broad aspect, it is a wide complex tachycardia ECG. So on the basis of this wide complex, he was misdiagnosed outside as a ventricular tachycardia. Anyone which see this kind of ECG, they mistake as a ventricular tachycardia, and for which he was given IV amiodarone every alternate day. So receiving IV amiodarone every alternate day in a 6-year child, the side effects are significant, leads to. So on the basis of that normal ECG, this wide QRS tachycardia ECG, how we differentiate this ventricular tachycardia with other supraventricular tachycardia with aberrancy. In ventricular, it is wide QRS more than 160 millisecond, and in SVT it is less than 160. AV dissociation is present in ventricular tachycardia. It is absent in SVT. Capture and fusion beats are present in ventricular tachycardia. Positive and negative concordance throughout the chest lead are present, whereas it is absent in SVT. Absence of typical RBBB or LBBB morphology, whereas it is present in SVT. Right bundle branch block and left bundle branch block morphology is present in SVT with aberrancy. So on the basis of this criteria, we came to a conclusion that patient is having SVT with aberrancy. Also the 2D echocardiography, this is the parasternal long axis view and a fourth chamber view, inverted view, which is showing that the chamber size, left atrium, right atrium and the left ventricle, right ventricle, they are normal in size, not hypertrophied. Valves are normal, no valvular leak present. So overall the 2D echocardiography is normal. This is the report. So a summary, a 6-year-old boy with recurrent paroxysmal palpitations since 2 years, diagnosed outside as ventricular tachycardia, for which he was given IV amiodarone or verapamil repeatedly, no significant family history, ECG suggestive of a regular wide complex tachycardia. Blood investigation, hemoglobin is 12.3, rest investigation, electrolytes, create serum 138 millimole per liter, serum potassium 4 millimole per liter, serum creatinine 0.3 milligram per deciliter, serum TSH 2.6, and calcium all were within normal limits. So this is the differential diagnosis which we discussed earlier. Now on the basis of my examination, the systemic examination, ECG and echo, we rule out the non-cardiac causes, that is hyperthyroidism that reports serum TSH and normal, electrolytes are normal, Patient was not having anxiety because he has we have that ECG, proved ECG was there. We have differentiated SVT, supraventricular tachycardia from ventricular tachycardia, long QT syndrome, short QT syndrome, Brugada. The patient was having normal QT interval. Brugada is ruled out. Hypertrophic obstructive cardiomyopathy is ruled out because the patient has normal echocardiography, no any history of any sudden cardiac death in family, no any congenital heart diseases from the basis of echo. So we are remaining with supraventricular tachycardia with aberrancy it is. So now we will proceed for electrophysiological study to confirm the diagnosis and to find out which type of supraventricular tachycardia it is. Now the issues in this case is the age is less than 10 years with child weight is less than 25 kg, and we required at least 3 femoral venous access to proceed for electrophysiological study.
Honorable Emeritus Chairperson Swankar sir, all dignitaries, my senior colleagues and dear students, yes, I am here, femoral vein cannulation in children. You also wondering, I am also wondering, such a basic topic in CCR, yes, it's an error of fraction of millimeter error. So it's very essential. Yeah, I agree. Rajiv and all adult cardiologists are very good taking the IV lines, and our colleague Nikhil, intervention radiologist, they are also very good. But it's a 6-year-old child, so they take my opinion in this case. I am cover few basics which is essential for this case. It's not such a basic femoral cannulation. The simple thing, basic procedure for intervention cardiologists. Thousands of cannulation we have done, adult, pediatrics, intervention radiologists or ICU people, thousands. The basic anatomy, vein is medial to artery, just palpate the artery, put the syringe, blood will come out. Now, once you secure the femoral vein, put the sheath, depending 4F, 5F, 6F, based on the age and weight of the child. In adults, it's very simple, they put 5 and 6, but in pediatrics, every weight, body surface area, height, we need to chase the different sheath, because if we put an error in this, vessels injure, whole intervention can't be done. So, what peculiar about this case? Weight and age of the patient. What is the weight? 20 kg. What is the age? 6 years. What is the height? 120. Electrophysiology study, which is a long study, takes some time, long time. So we can't say how much time duration we need that sheath to be put. And 2 sheaths inserted in one femoral vein, 3 sheaths on the other side of the femoral vein. So that's the challenge. How to choose sheath in the small femoral vein? Basic. Femoral vein depth and diameter correlated with the size, weight, body surface area studied in the pediatric patient. Such estimation may facilitate the choice of vessel to be cannulated, length and diameter of cannulation needles, diameter of catheter used in the pediatric patient. So we need a lot of hardware knowledge to proper cannulate a femoral vein. In this case, we need to put 2 sheaths, so all it's important. The first basic thing we put with the IR people or with ourselves, monitor the size of the vein and artery. Vein are collapsible, non-pulsatile structure. This is the thing we measure, or because so much procedure are done, so radiology people make few nomograms. So what age, what weight, what height, what is the normal diameter of femoral vein? That helps us to conduct the procedure. So they put all the based on the age, size, weight and body surface area. Our patient is height is 110 centimeter, so approximately femoral vein diameter is 0.5 millimeter, 5 millimeter to 5.5 millimeter. Now we need to choose sheath according to that. In that case, height is 110 and weight is 22. Now, femoral vein diameter is, as per nomogram, is 5 to 5.5 millimeter. Plan to insert 2 sheaths in the groin, 6F and 8F, and left groin 7F. Rajiv called me in the cath lab, so we want 2 sheaths to be inserted. But before that, choose the sheath. We have a knowledge which type of sheath to be inserted, what is the diameter of femoral vein. So I take the weight, height and everything of the patient, which is given in the file, and take on the nomogram. I make myself sure it should not be more than 5 millimeter. So what is the meaning of this F? We use all type of sheath. What is the meaning of F? 5F, 6F, 6F, 8F. What is the meaning of F? That is the key in that. So F is the internal diameter of sheath. 1F is denoted to 0.33 millimeter. So 5F means we multiply 0.33 into 5. 6F we multiply 0.33 into 6. 7F 2.3 and 8F 2.64. So femoral vein diameter is 5 millimeter. I need to insert two sheaths. One is 6 and one is 8. If you add internal diameter of both, it will come 2 millimeter and 2.64. Yani 2.64 millimeter vessel diameter I need to put two sheaths. So margin of error is very small and side by artery is there. If I put one sheath wrong, vessels damage, no procedure can be done. So this is the basic. When we do the femoral cannulation, the good idea what sheath need to be put. Why this is challenging? Because we want to put one vessel, two sheaths, and you see the diameter, how critical it is. So this is the chart we have all in our cath lab. What is the internal diameter of every sheath? And based on this, we are successfully put, luckily in the two prick, 8F and 6F sheath by the color, blue for 8, green for 6 on the right groin and left groin 7F. My work is here to just put the sheath, which I put successfully with the God grace, because IR people are also there, machine is also there, but they go with my experience. Okay, you put manually, we tried and we are able to get the sheath. Now my work is done. Then I will the cath lab to see the magic of Rajiv, magician. Here I come to treat the arrhythmia. Come Rajiv. Yes, I agree. Initially I told they are the safest method. It depends upon the training. I put femoral sheaths in 20 years in our training. First 12, 15 years, no ultrasound guided probes are there. So we do like this, even 2 kg baby, 3 kg baby. Whenever we stuck once in a 5 months or 3 months, we take the help of Nikhil is there. Because intervention radiology people are, it's easy for them to guide the vessels under the probe. But we are doing daily and daily. So generally we comfortable. The 6-year child, we are most comfortable. They are also can do if a single sheath to be put, but here 2 sheaths are put. Rajiv.
So why do you need 2 sheaths, Rajiv? Like you need guide
Rajiv.
wires to be put, no? Why can you not put 2 guide wires through one large bore sheath only?
So I'll show sir how EP is done, EP study is done. So thank you sir. Sir helped us a lot in this patient because veins were small and we don't want any complication. In EP study at our center there is no complication till now and we don't want also this, any vascular complication. So sir helped us. So what is electrophysiological study? It is ECG from inside of heart. As we are doing from outside, it is inside of the heart. So it is a specialized test to evaluate cardiac electric activity and how conduction goes in heart. So there are 2 catheters we can see. One is this 10 poles catheter. Is the projector? Yes. This catheter is having 10 poles. This is on right atrium, and this catheter, this is having 4 poles. So by this we localize where is the impulse originating, what is the abnormality, how pinpoint we can localize the problem and can solve it. So sir, we need 2 sheaths for these 2 separate catheter and 1 for giving RF energy. I'll show later. So we need 3 sheaths at least. No sir, its movement will be difficult if we insert. And second, if we use 1 sheath and 2 catheters, first movement will be difficult, and one larger sheath is having more complication rather than having 2 small sheaths. So this is the console of the electrophysiological study. We can see these green signals are atrial signal, yellow signals are ventricle signal, and we can correlate with the ECG on the top. So what is going on in myocardium conduction system, and this is the console of the how we stimulate the heart. This is how EP study is done. We can see here what we see ECG is a gross. What we see inside EP study is minute details of the conduction system. Here we pace the atrium, the green signal is atrium, and we can see what tachycardia is induced. Once tachycardia is induced, as is this patient, we can see the EGM, tachycardia ECG. We correlate whether this is the same ECG or not, and then we find out where is the source of this circuit. So after doing this study, diagnosis was Mahim antidromic tachycardia, now commonly called as atriofascicular tachycardia. It's a rare tachycardia. ECG of this tachycardia mimics with ventricular tachycardia. So although he was misdiagnosed, but that is a common problem because any wide QRS tachycardia, initially responding with verapamil, but in long term not responding, only responding to amiodarone, any physician will diagnose it as ventricular tachycardia. Even our residents also diagnose it as ventricular tachycardia. So it's not wrong to diagnose this as ventricular tachycardia, because it's in rare tachycardia and terminated also with the amiodarone. So they were right at that point, but what was happening, he was almost in hospital. जाता था छुट्टी में, next day वापस admitted, and he is not from Bharatpur, he is from Badmer. From there he was referred by cardiologist. He was going for routine OPD clinic, and then he diagnosed as ventricular. He also diagnosed as ventricular tachycardia. Then he said, because echo is normal, then why don't you go for ablation? Then he came to us. So any arrhythmia which 2D echo normal can be ablated with radio frequency ablation. So this is MGUMST tachycardia. As we know, there is only single circuit from atria to ventricle, AV node. But in this, there is extra circuit from right atrium to the right bundle branch. So the atrial activation leads to direct activation of ventricle without involvement of AV node, and tachycardia get initiated. So it's a decremental pathway.
So Rajiv, with your EP studies, you could diagnose the abnormal focus where it started and where it was going. You could do that?
Yes, sir. EP studies that only, because ECG, on ECG I also diagnosed that it is MGUMST tachycardia. We diagnosed that it must be supraventricular, but on EP study we confirmed that this is this tachycardia, and which is very uncommon in 6-year-old child, because we have done around 11 or 12 cases of this MGUMST tachycardia. Everyone is more than 20 years. So treatment options, as sir said, vagal maneuvers, carotid massage, IV adenosine, beta blocker, calcium channel blocker, and anti-arrhythmic. But problem in all these medication in this particular case was because all these medication mainly act at AV node, and problem is side by side. There is other tract beside AV node. So that's why this patient initially responded to verapamil, conservative measures, but then required repeated admission, and finally definitive treatment is radiofrequency ablation. So this one is the catheter. So we have 3 sheaths, one for these 2 catheters, EP catheters, and this is radiofrequency ablation catheter, by which we give radiofrequency energy from the back of heart. There is no surgery needed, no incision needed except for the femoral vein insertion. Can I show one video done yesterday, because although patient's face is seen in this because video. Can I show?
So I think before you do that, how exactly do you localize that this is the tract and now I am placing my RF ablation catheter on the tract? So what is the real-time localization that helps you to place the catheter accurately?
Okay, sir.
And the other question was that this is a 6-year-old child. You said most of the MGUMST patients are more than 20 years old, but this aberrant conduction pathway should be there since birth.
Yes, sir.
Why does it get activated so late? What is the reason why they don't have it all the time?
So, sir, it's like graying of hairs, because with age, AV node gets slowed and the pathway will remain same. So it is relatively pathway becomes stronger as the age advances. So that's why it presents relatively later in the life. But in this particular case, it presented early and became incessant. And sir, how we localize? It's EP study, because if you see this slide, we are pacing the atria. First, there is narrow QRS on ECG, if you see, but suddenly turn to the wide QRS suddenly, with one signal, his signal, which is get buried into the QRS. That is diagnostic of this pathway. So after that, we see do radiofrequency ablation. We are doing in local anesthesia. We are not sedating patient routinely, except sedating So how we localize is by this signal, sir. We can see the ablation distance. This one is the electric signal, and in between these there is a small potential. This So this is the point of localization. It's like hunting the treasure. So we have to localize where it is, and then we can give the energy here.
You keep moving the electrode, and where you get that signal, that is the point.
Yes, sir. Yes, sir. But we localize with the through catheter whether it is right side, left side, right side, whether it is up or down, and then find localization with this catheter. And this is the final ECG of this patient. So we see purpose of this CCR is to get awareness for this easily treatable disorder, which patients are repeatedly get episodes of palpitation, IV medication and all. And if you see, the duration of therapy is only 3 minutes 13 seconds. Radio frequency, and job is done.
So you have some evidence, confirmation that yes, now the focus is ablated. Do you stimulate or provoke it in any way to make sure that you have completed the job, or something might get left behind?
Yes, sir. We what book says we should test for 20 minutes, because if abnormal pathway is there, it will come immediately. But book says wait for 20 minutes. But what, as we are having very strong team of our residents, they used to stimulate for 1 hour. So luckily we don't have any recurrence in all 11 patients, and all our patients, not this one, all our patients are doing well. I'm not saying that I am doing good, but it's the duration, post-procedure duration of testing. They are doing for 1 hour. So after 1 hour, if it is not coming, that it will not come in future for sure.
Any injury to the myocardium because of the radiofrequency ablation that might pose problems at that time or later?
No, sir, that's what I'm saying. It's 3 minutes job only. It's hardly any problem. We have not seen any long-term complication till now.
Endocardial injury also, no roughening of the endocardium. Endocardium,
Yes, sir.
no roughening, no antiplatelets needed.
Sir, animal studies are there which says no injury with radio frequency ablation. And if you keep the duration small, then there is no risk.
You don't give any anticoagulant.
We give aspirin. We give aspirin for few days. Yes, sir. For 1 month.
Do you do some follow-up echo to see any clot?
So we call patient after 7 days, and then 3 months, and then yearly. So this is the largest series of 15 patients from Shri Chitra Institute of Myum Fiber Tachycardia, and of which 14 patients underwent successful ablation. This one also largest series from international, which was published, 55 total patient, in which success rate was 91%. It is left. Myum can be also left side also. That is called as left side. I do. Only 2 case reports are there for that. So now he is going to school, doing well, and we just talked yesterday. No tachycardia, no medication, doing well. So just 5 more minutes. Number of EP cases at our center. We have done more than 1300 cases in last 6 years, including pediatric cases. So difficulty with pediatric cases, we usually wait for 10 years of age and 25 kg of weight. But we are doing, especially once Sanjay Khatri sir has joined, so we are doing 5 years, 6 years, 7 years across all the ages. And initially during COVID times, the number was less, but now with all your supports, it is increasing gradually. Until now, we have done around 200 procedures. So, with blessing of God and all your supports and our strong resident support, our data are comparable to most centers, most high volume centers across India. So, if you see, UN Mehta is doing maximum cases, but our data is also very good and gradually increasing. Safdarjung Hospital. अच्छा, sorry sir. Yes sir, वो सर कल रात को ही डेटा आया था सर, तो sorry. And most important is that we have zero mortality till now in this procedure. In stenting MI we can have mortality, that is accepted, but in this we till now we have no mortality. All patients are medication free. And if you read Harrison, it is written in cardiology. This is the only specialty of cardiology which is treatable. If you want one cardiology disease, you should get SVT because this is 100% curable. So, take-home message is Mahatma tachycardia, as we know, significant cause of refractory palpitation. Diagnostic challenges, as we have discussed, it is usually diagnosed as VT. EP study and RFA can easily and effectively treat this condition.